Today we have Slate. That's our
Sponsored by
sponsor
Slate.
today.
Make this the promo.
Yeah, the promo. Welcome to the STAT podcast, where we talk about the pre-PA life, PA school, and the PA you always dreamed of. Today we have my psych rotation buddy, Megan Daniel. She is from Kennesaw, Georgia. She completed her undergrad in exercise science in 2024 from Georgia College and State University. She currently attends Medical University of South Carolina PA Program and is set to graduate in 2026, just like myself and my other classmates who have been on the show. Today, we talk about different topics, from her decision to go to PA school, her medical mission trip, and how to transition from didactic year to the clinic year, especially going into psych. I really enjoyed this conversation and I learned a lot. I hope you learn something too. Thanks for watching. What made you choose PA school and just the PA profession compared to other fields like physical therapy and med school?
Yeah. So when I was in high school, I was a junior. My grandma had stroke-like symptoms. I was taken to the hospital and was diagnosed with a stage 4 glioblastoma, which is a really aggressive brain tumor. And they decided that she ended up going to Texas. They couldn't do surgery. And so she lived about an hour and a half from our house. And so my mom actually kind of ended up moving in with my other aunt into the house to take care of her, and they would take turns. And so our whole family kind of just stepped in to take care of her because my grandfather had passed a few years before that, and she was living alone. And so she went from managing businesses and taking care of 7 grandkids and herself to kind of needing full-time care, because then she decided to do chemo and radiation. That happened in March. And so when I got out of school, like school ended in May, I spent most of that summer kind of going back and forth, playing softball, seeing friends, but then would go and stay a week or stay a weekend and help my mom take care of her. And so seeing the rapid decline in her cognition of, not being able to move certain parts of her body, her personality changed a lot. But I loved taking care of her. She was someone that I really looked up to, especially in my faith and what I believe in. I just loved the way that she loved and cared for people. So I was thankful. She had taken such good care of my whole family for so long that I loved being able to take care of her. And so at that time, I was actually going through physical therapy for lower back problems, and just loved my physical therapist. Like, I looked forward to going to PT. I loved being able to move my body that way. They were so kind and just made it fun. And she loved her physical therapist too. And so I remember I told her I wanted to go to PT school, and I have this video of her telling me how proud she was of me, how she loves her PTs. And so being able to take care of her, give her medications, just be there for her. I would help her take showers and baths and help her go to the bathroom. I just loved being there for her. And whenever the doctors would talk to her, I wanted to understand what they were saying about her condition. And so I was going to go to PT school because I played sports growing up, went to college and did exercise science. And then when I was in anatomy 2, we were doing a lab on diabetes, and we got a case study and we had to figure out that it was type 1 or type 2 diabetes. And then we had to understand the mechanism of action of the medications and why we would give that medication. And I remember sitting there and being like, I would never do this as a physical therapist, diagnose diabetes and prescribe medications for it. And so I started to kind of think again of doing physical therapy, and I had done some hours in a PT clinic and really liked it, but didn't know if I loved geriatrics, and that's kind of what I was doing. So I was like, I don't know if I want to do PT school anymore, but I didn't know what else I should do. So I thought about nursing, but I was kind of behind the curve of getting into nursing school, and I didn't want to do the 4 years of med school. And so I had some friends that were already on the PA track, and I talked to them about what a PA does, and just switched to it, still really not understanding what it was until I think I started PA school, and we had a class that's what is a PA? And that's when I kind of figured out what it was. But I just loved taking care of people, and
they say it's the first most sought out job now.
Yeah, it is now. And I had no idea really what it was. But then you tell people you're going to PA school, and they're like, good for you, okay. I still was like, I don't really know what that is, but I just want to diagnose and prescribe medications. I think it's so interesting.
It's funny how we start clinicals and we still question that role.
Oh, yeah.
But at the end of the day, like I'm satisfied with
Yeah.
what I do during rotations.
Oh, yeah.
So, and I think that's a great experience because a lot of people who go to PA schools have that personal story to back them up, and I think that's a strong desire, and I think that's just a strong purpose for them to keep going forward and maybe prevent burnout. Because
Yeah.
whenever I think of like times getting hard, or when I look back at my didactic journey and how there was like 3 exams a week and like OSCEs and everything, and I was like, I looked back at my grandma's diagnosis of Parkinson's and how that helped me with my decision to go to PA school. And just looking back and thinking all that stuff makes me just move forward day in, day out.
Yeah.
And so I think that's a beautiful driver too.
Yeah.
Speaking of going to PA school, you went on a medical mission trip for 10 days. What does the medical mission trip, or just you had a mission trip in undergrad and in PA school. But what does medical mission trips mean to you specifically?
Yeah. So for me, I've always believed and have known, like, and seen the way that Jesus has served other people. And so for me, medical mission trips are a way for me to serve other people. In undergrad, it was different because I didn't have medical knowledge. I mean, kind of like just from extension of other people, but I didn't know really how to treat people or what to do. And so on that trip, I was more of a translator. We were in Guatemala. Versus this past medical mission trip, I had some understanding of a lot of diseases and was able to actually kind of aid the providers. But for me, like when I look throughout Scripture, so many times in Scripture, the first thing Jesus, when he encounters someone, the first thing he does is heal them. He doesn't go to them and say, do you believe in me? Do you believe what I'm saying? Do you believe what I'm preaching? Are you doing X, Y, and Z? Okay, now I'll heal you. He just touches them and heals them. There's no like prereq for him to extend his power and his grace to them. It's just a matter of he loves them because he created them, and so he's going to care for them. And so for me, it's like I don't need someone to come to me and meet A, B, and C for me to treat them and take care of them. I just want to love them like Jesus loves them, and I'm going to take care of them regardless of if they meet these standards. And so there's no requirement to come to be healed. It's just I love you. I want to love you the way Jesus loves me, and he came to me, and I didn't have to like be perfect and have it all figured out. He met me where I was and healed me there. And so that's the same way that I view missions, is like I'm going to go and I'm just going to offer what I can offer and love you well. And so I think just being willing to go and say yes, can be tiring and exhausting, especially like with Africa. It was a 16-hour flight, and then we had to drive 8 hours, and then there was a time difference. But I mean, it was completely worth every second that we were there, of being able to like take care of those kids, and not necessarily even just physically take care of them, but like blow bubbles with them, and pray over them and pray for the kids and pray for the nurses. And I don't know, for me, it's just a way to love people like Jesus, and it's an opportunity. Like he's given me this knowledge for a reason, so I want to use it to glorify him and give it back to him. So
I think it's such a beautiful perspective. Coming from a Hindu perspective here, one of our sayings is like, do things regardless of the results. So enjoy your journey.
Yeah.
So whatever you're doing right now, just enjoy the full of it and don't just expect the results. And I kind of like that idea too when I think of like other religious perspectives, because I'm spending a lot of time in clinical rotations to develop like my mindset of how to become a good provider. And so last podcast that I had with one of my classmates, we were talking about poor provider skills. And so from that, I learned that you can be deficient in knowledge, physical exam skills, but you can also be deficient in just not seeing people as equal.
yeah.
And I think that could also be a huge barrier. And it is definitely beneficial for even people like me who are immigrants to someday do medical mission trips, not just people, just white people in
Yeah.
America, but just colored people who have like people of color who have been here for a long time, just maybe go out for a mission trip
Yeah.
and just explore what they could offer.
Yeah.
And I think that would change your perspective, which I want to ask you about is how did that experience change your perspective as a PA student as you move on through your clinical journey?
I think it made me more humble in a lot of ways. It made me more excited too. Like I have loved medical missions, but then when I was actually able to go on this trip and kind of know more, not everything that I was doing, like there are some things I was like, either A, haven't learned that, or B, I don't really remember that, but I still had more knowledge and I was able to provide more care. Like one of the days on the trips, he was like, okay, you go, like you have your own station. I'm going to give you a pre-PA, like I'm going to give you a PA student to be with you, one of my friends. And I was like, okay, sure. And just seeing what the Lord could have done in that moment of like, I had such confidence, and I think it excited me for when I am a full provider and on my own. And it just made me more aware of like the way that I can serve people through being a PA. And that's not just like in Africa or like in a different country. Like I'm serving people in every practice. I'm serving my preceptors on rotations. I'm serving the other students that I'm with by like being kind and being helpful, helping when I maybe want to go home, or helping when I'm frustrated or I'm tired, being kind to every patient that comes in. And then as a provider, like even if I'm working in an office, every patient that I see is an opportunity to love them well and serve them well. And like you said, like seeing myself just as an equal to, like not as an equal to them, but like we're both imperfect people.
Yeah.
I'm not always going to get it right. You're not always going to be in the best health. And so like, let's work together. I think just seeing it as like missions goes beyond just like traveling, but as a PA, like I can be there for people in my everyday job too, at the grocery store, anywhere.
Yeah. Going through 4 rotations total, what I have observed from my preceptors that whenever they have sat down with the patient and worked through problems together, in terms of the preceptor saying, I'm going to tell you what to do, having that way of being, like having that way of having empathy towards others,
Yeah.
especially patients, goes a long way in terms
Yeah.
of managing the patients and
Yeah.
actually patients listening to you, because now they feel more comfortable in
Yeah.
addressing their own issues.
Because like as a PA, I'm not any better than the person sitting in front of me. I have the knowledge and the skills that the Lord's blessed me with to be able to provide that level of care, but it doesn't make me better than the patient. Like the way I see it is I'm equal to everyone around me. We're all sinful people. We all make mistakes. I'm not any better because I'm a Christian. I'm not any better because I believe in the Lord. I'm not any better because I have this religion or this knowledge or this education. We're both equals. It's just I've been given a position to help you, and I have the knowledge to do it. And so it's like I think as PAs and just healthcare people in general, they have this higher than thou stance sometimes. But it's just, we just have been given an opportunity to love that person well and give them the knowledge that we've learned. So if you work together and your patients can see you as a friend and a provider, I think you can motivate your patients so much better too.
I think humbleness goes a long way. It's a good thing you brought up, because I also think a lot about 20 years from now, am I going to be the same person in terms of treating patients? Because now I'll have like, let's say 20 years of experience.
Yeah.
And there's a certain ego attached to that.
Oh yeah.
And maintaining that humbleness is going to be tougher. And so I think starting to think about that like right now during our training it's very beneficial.
Yeah.
So we before this we were talking about some of the less common diagnoses or conditions you would see in Africa compared to here. So what are some of give us some like common things that you would see there which is uncommon in US?
So a big thing that we saw, so the school we were at was a special school. So in the States, there's at each school there's classes, you know, for special needs kids. In Africa, it's a huge school. So there's a physical disability section, a blind section, and a deaf section. The first couple days we saw, 2 days, I think, we saw the physical disabled section. which is where like majority of what the different things I saw were. So spina bifida and cerebral palsy, which are common in the States, but with prenatal vitamins in the States, it's not as common because it's more prevented. And also diabetes in the mom is really common in Africa versus it can be a little bit more controlled here. And that's a predisposing factor. And so that was a big thing we saw. But some random things we saw were we saw something called Cruzon syndrome. It's a genetic disorder where the facial bones and there's premature fusion of the skull bones, and so it can cause proptosis of the eyes and just a lot of eye issues. A lot of kids in the States will have to get surgeries all the time, but in Africa they don't really have that access. We saw a lot of trying to think what else we really saw. We saw xeroderma pigmentosum, which is not common in the States, and it's not common really in general at all. But the little boy that we saw, pretty much from here up, everything was so much darker. He was completely like scarred and wrinkly, and he was probably 11. He was also blind from birth, and then he had his lip protruding kind of like this and just like precancerous lesions all over his lip because he's just so sensitive to the sun, and they had no idea. So he's been playing outside for years with no idea that the sun is so damaging to his skin. Like he can't replace the melanin. He doesn't really have melanin. Albinism was really big, which isn't really common in the States, but I think there are about 15 kids with albinism. So we had to do skin checks, removing moles, precancerous lesions. The backs of their necks were like completely wrinkled from the sun, and they're 11 and 12 years old, and their skin looks like they're 60. So I think those were the big things. And honestly, a lot of it was a lot of parents just had no idea what their kid had. So we had a mom come in and her daughter had cerebral palsy and her hand was, like this, and she couldn't really move it. Her mom was concerned about it. And I had to ask the mom, do you know that your daughter has cerebral palsy? She had the diagnosis on her form. Her mom had no idea. So then I had to explain what cerebral palsy was and how that's pretty normal for her. She just needs to go see physical therapy and occupational therapy. And her daughter was able to go do that because we had some PTs and OTs there. One little girl had muscular dystrophy and couldn't walk, and her mom was like, well, she can't walk. I'm concerned. And I had to tell her what muscular dystrophy was and how that's natural for muscular dystrophy and how over time it's just going to get worse. There's not really much you can do. And so a lot of it was just education.
Yeah.
Like people, and that's the same for the States.
I was going to ask, how did you have to learn how to provide patient education, or how did you get better throughout your days there?
Yeah, that was hard because especially like they spoke a language we didn't necessarily. Some of them spoke English, but we did have translators. So a lot of it was just I had to kind of dumb it down in a lot of ways, and honestly explain it in a way that I had to explain it to myself during PA school.
That's like, how it is. Yeah,
it's a genetic condition, and over time, this is what you can expect, but with someone with muscular dystrophy, they're going to lose the ability to walk, and they're missing the protein that they need for muscle growth, and so over time, like I had to explain to her, like she's going to have issues with her heart, and she's going to have issues with breathing because your lungs are a muscle, and so you really need to take her in for regular like heart checks and checking her breathing. But I didn't even have the heart to tell her, like, for muscular dystrophy, the average lifespan's like 20 to 30s, and I think it was just kind of being empathetic too, and providing sympathy of like the daughter with cerebral palsy, of like, this is the way your daughter was born, and there's nothing wrong with her. She's beautifully and wonderfully created. You just have to provide special care for her, and this is the best things that you can do for her. I think just explaining it in a way that was kind and compassionate, but it was a struggle at first because I was like, they have this diagnosis on their form, but no one's actually ever told them this, like what it is.
Very sad, yeah.
It's really sad. Because they're concerned for their child, but they don't have any knowledge. They're just like, this is so abnormal. But then when you explain it to them, like, well, for their condition, this is normal. So like it kind of relieves some stress for them, but also then they're hearing that diagnosis kind of for the first time. So I think just kind of giving them the resources of like, this is the best thing to do for them.
So crazy how we take things for granted here.
Yeah,
when
even
studying.
Just the ability to look up at ChatGPT or Google. Yeah.
It's crazy. It's like we know how to diagnose people from question banks. And sometimes clinical rotations will also like, let's say my primary care rotation, like when I got a diagnosis, I'm like, yay.
Yeah.
But then when I hear these stories, I'm like, I don't know anything. And it's fine, because this is the beauty of medicine. Like wherever you travel, and if you try to learn these different conditions, it's just going to add to your knowledge. And you just got to, again, stay humble and try not to be that cool PA kid, PA student on the mission trip who knows everything, but actually sits down and understands everything and tries to learn everything, absorb like a sponge. And I think that's a great experience. I might do that sometime in the future.
I think it's great because it takes you out of, especially in Africa, like they don't have, you can't just be like, oh, I'm going to refer you to cardiology. I mean, we did do that, but the odds of them going to do that were probably pretty low. But there's not all the tech that we have. It's more of like, we could treat some stuff like with antibiotics or creams, and we gave all the kids vitamins while we were there. But a lot of it was just like, we didn't really know what to do for some of them. Like they had a different heart murmur, and we would refer them, but there's nothing we can do to treat it. Was there a ChatGPT? We did have UpToDate on our phones. So I didn't have service, but some of the providers did. So we used UpToDate a lot. But we had 2 PAs and we had a doctor with us and a dermatologist. So we covered and PTs and OTs and speech language pathologies. Like we covered ground. But there was a lot of like, we're going to do everything we can, but like we can't do an ultrasound or a CT scan or... We just have to manage what we see at hand. So a lot of skin stuff we could treat, like impetigo or ringworm. Other than that, it was, we could treat some other things like with antibiotics, but other than that, it was kind of just like, we're going to write you a referral, but the odds of them going are slim. We're just hoping that they can get in. Or the nurses will take them.
Beautiful. So that was before clinical started.
That was right after.
That probably boosted your confidence too.
Oh yeah. We went in May, and then I still had one more semester of classes. So like a lot of the derm stuff we saw in Africa, I hadn't learned derm yet. So I was like, I don't know what this is. But it did help me when I got to that block. I think it just made me more excited for clinicals of like, I had that hands-on experience. And I was like, I want more of this. So I think it just made me excited to kind of get through the summer. Yeah, once you taste clinically, you're not going back. No, not at all. No. Okay, speaking of transitioning, this is like flowing pretty good. What have you noticed? Because this is her first clinical rotation. What are some positives, negatives, starting clinical rotations? I think positives, I think it's really easy to look at the positives because you go from sitting in a classroom from 8 a.m. to sometimes 5 o'clock, noon, and then studying on top of that when you get home, to you're on your preceptor schedule, and some schedules are really nice. Some schedules are a little bit more hectic, but I think before, the biggest thing that changed for me, and I think I kind of got this way towards the end of didactic too, because I got more of a grip of like, what works for me, how do I study? Of like, my day-to-day was, what do I need to do for myself? Like exercise, cook, hang out with people or whatever, go to a church event or whatever I wanted to do for the day, to like squeezing in school. Versus before when I first started didactic, it was like school got the priority and I was squeezing in everything else. Like my workouts got shorter, my like time alone at night got a little bit shorter, my time with friends got less. Like I would spend more of my time hanging out with my friends from PA school, and they became my great friends and still are. But it was like we would study together, and that was kind of like our fun time, instead of it being like, oh, on Saturday I'm gonna take the day off and like go to the beach. PA school friends are hard. You know why? I feel like I still am being trapped when I say I want to study with them. I think my brain wants that fun, not study. Yeah, for sure. It's a trap. It is a trap. Because every time we'd start studying, we'd like get off on a tangent and be like, okay, go back. Go back. But it definitely became more like with clinical year of like, okay, I can squeeze in studying to my daily schedule and like make it work. And I can afford to take a day off and not study. Like our preceptor told, not our preceptor, but our like clinical year instructor kind of told us like, treat your clinical as like a job. Like you're there to like learn and study. You're kind of studying while you're like learning while you're on the job too.
Yeah.
And then like take the weekends off if you can. Like, which is before in didactic, I felt like my weekends were my catch up.
I think that's a interesting take, because I never see myself taking weekends off. What do you feel like? I mean, you.
I don't take all the whole weekend off. Like,
Yeah.
I think I like the mornings, so I'd rather get up and like study on a Saturday morning or study Sunday after church for a couple hours.
Yeah.
Versus like, I think before I would like get up and study for 3 or 4 hours, take a break at lunch, go for a walk, study for a few more hours. Now it's like I'll get up and get my studying done in the morning, and then I can enjoy the rest of my day.
Okay. Yeah. So speaking of let's talk about like, okay, what the things that you did in didactic? No. What's the things that you started doing in clinicals that you didn't do in didactic? What are some things that you brought back to life?
Oh, like it personally?
In clinical rotations, yeah.
My workouts have gotten a little bit longer.
So what do you do for your workouts? And when do you work out? So for example, just to lay our schedule out,
Yeah.
it's what, Monday, Tuesday, Thursday, Friday, 10 a.m. to
Usually 8.
8.
Earliest I think we've ever gotten out 6:30, and that was once.
That was, yeah.
Consistently 7:30.
Consistently 7:30.
Latest I think we've gotten out to 8:30.
8:30, yeah.
Yeah.
Yeah. And then, so you work out when? In the mornings?
Yeah, I get up around 5,
Okay.
5:10, and I'll lift. I'll do like workout videos.
This is at home workout, right?
Yeah.
Okay.
Yeah. My apartment has a gym, so usually I'll go down there if I'm at my apartment, but I'm in Savannah right now, so I have a bunch of free
Don't
weights.
reveal the locations. They're
Well-
gonna come get me.
Sorry.
I'm kidding. I'm kidding.
Not in Charleston right now, so, but even then I just kind of use dumbbells.
Okay.
So workout videos, like 40 minutes, maybe 30 minutes. And then right now I have time to go on a walk after that just because we don't go until 10.
Yeah.
Whenever I get to other rotations, I'll probably either try to walk in the afternoon or just not walk that day, depending on my schedule. Some days I'll go for a run. It really just depends. But right now, up at 5, and then I try to sit down and be like eating breakfast and studying by 8, and then I can get like a good hour 15 in. But I also like get up, drink coffee, do my quiet time, and then I'll work out. So I have like a little bit of a routine.
How many times do you work out in
A week?
in the week?
I'll lift 4 times a week.
Okay, so you lift 4 times a week, and then your study sessions are usually like from 8 a.m. to 9:15-ish.
Yeah, and then I'll study while we're there, like practice questions or looking things up, blueprint questions, stuff like that. What about you?
Me? So, okay. First week I was all alone. That means I didn't have you.
Yeah. Was it just the first week or was it 2 weeks?
Probably 2 weeks.
I
So
think it
2
was
weeks
2.
I was all alone.
Yeah.
Not alone, meaning with the preceptor. And I didn't realize there was a lot of sitting. So I would get up. So I changed my routine after you started, because then I realized, okay, something has to change because I'm getting miserable. First 2 weeks were like a lot of sitting. First week was totally virtual. But I was waking up around 6, studying for 2 hours, 3 hours, and then coming on to do my shift, and then going home, and then not doing anything.
Yeah.
I mean, just studying a couple hours in the morning and then not doing anything. If I got out early, I would go to the gym,
Yeah.
but I wouldn't make it a priority because I didn't know what time we would get off.
Yeah.
Reason why I working out late in the day is because I need to have some food before I work out.
Yeah.
But then what I did is I stopped working out on work days, mostly at all. But I started walking in the mornings because we are deficient in steps.
Yeah.
So now I'm just waking up, taking a little mile walk, and then starting to study. So I'm getting a little bit of activity in, and then I'm like similar to you.
Yeah.
But I'm not like having a hard workout.
Yeah.
That's the only change in my schedule.
Yeah.
And it's pretty similar to yours, but I do get around 2 hours of study time, maybe an hour and a half.
Yeah.
But I think that is enough for psych.
I think I got lucky in the fact that psych was my second to last block.
Yeah.
And so I just had it over the summer. So when I started studying it again, I was like, oh, I remember this. it definitely, especially with the meds, a lot of refresh.
Yeah.
But I didn't feel super overwhelmed of like by the content. It wasn't like the blueprint is that long. It's like 2 pages. So that's been a blessing of like, I need to review, but I also have 4 weeks to study 30 topics. And I just kind of finished studying it not that like 3 weeks ago. So it wasn't too much to kind of catch up on, which was nice.
Yeah, psych, and I think people say OBGYN is hard. I can see how it could be hard. Depends on how much study time you get during your rotations.
Yeah.
But I think for me, psych and OBGYN have been easier. That's just my opinion because how specific they are.
Yeah, they are very specific.
Primary care is very overwhelming because it's a lot of information. Plus you have to work 40 hours a week-ish. So just think about you, if you are in primary care right now, you would have to probably study double the amount of hours.
Yeah.
Because psych is just not a ton of information.
Yeah.
But primary care is huge. Internal medicine, family medicine, what is the other one? ER, internal and family.
Yeah,
so they're just huge topics. So,
but what's hard about psych too, like it's kind of like a tit for tat of like, with those, there's so many topics.
General.
It's like a top, they just skim the surface versus psych, like they can really get into the weeds.
Oh yeah, they can med the meds and stuff.
The meds, and then like I've heard that the neurotransmitters, especially for the meds, are very specific, and like the neurotransmitters that are deficient in depression and anxiety and all of those, like I've heard that can be kind of thick on the exam. So it's like a tit for tat of like.
I got a biochemistry question.
Yeah, I did too. On cocaine withdrawal or something, and I was like, it talked about the biogenic amines. I was like, I don't even know what that is.
This is not the place to ask those questions.
No. Some of the blueprint questions, I'm like, I don't think that's important, and I hope I don't have to know that, so I just skip it. I just hope that I don't have to actually know that for the exam. But I don't know. It has been nice. I think going from didactic to here, and then I'm thankful this is my first one. Like my roommate is in internal medicine first, and I know it's been overwhelming because she looked at the blueprint and was like, so she has to cover 8 topics a day.
8 topics a day, okay.
To stay on top of it.
We'll figure it out though when we have internal.
Yeah, but it's a lot. It's a lot. So I'm thankful that my first one was a little bit more baby steps.
What are some tough psych things you have encountered studying for this EOR coming up?
Bipolar and schizophrenia, especially the bipolar treatment.
When the question starts with like any hallucinations and psychosis symptoms, I'm like, this could be like 3 things.
No, I know, because it could be major depression with psychosis. It could be schizophrenia.
Yeah.
It could be bipolar with hallucinations and delusions.
Yeah. It could be substance use.
Yeah, you never know. It could be ecstasy.
My brain just goes blank.
I know, I do too. I always just look at the answer choices and I'm like, okay, well, it's talking about like antipsychotic meds, so they've got to have like maybe schizophrenia or something. I don't know.
Yeah.
They're tough.
Are you struggling with anything particular in this rotation right now?
Like with studying?
Like anything apart from, just studying and stuff.
I think the bipolar meds get me sometimes.
Yeah.
Especially because sometimes you can just do monotherapy, and then sometimes you need to do like what's different that I've learned too is in our textbooks it says lithium or valproate plus 2nd generation antipsychotic. In practice, she never uses lithium or valproate, and for good reason. They have so many side effects. But she'll use like a mood stabilizer instead.
This is the best transition we have had in a podcast. Everything is flowing. Okay. So talking about, go ahead, the med management.
It's totally different than the book.
Yeah.
So that's been an adjustment, because then when I'm doing questions, I have to revert back to the book and be like, what did I learn in class? What does like Pants Pearl say?
Yeah.
But then when we go into office, like lithium valproate are out the door. That's been an adjustment.
Yeah. So our preceptor asked, this was me when I was alone, something about what would I use for acute mania?
Yeah.
And I gave her a textbook answer. Well, lithium has all these side effects, so I would probably use valproate and maybe antipsychotic. And then she's like, no.
Yeah.
I have not seen good results with valproate. I'm like, okay.
Yeah.
And what should I use?
Lamotrigine.
So lamotrigine. So all these like nuances and which I really like.
I do too, because they have so many side effects. So it's like you're looking at the patient in front of you and trying to help them in the best way without causing so many side effects. And it's just been hard with studying because then I have to like throw out what she said.
You have to compartmentalize it.
Yeah.
So bad.
Yeah. And then substance use too is tough. Not necessarily in the clinic because I don't feel like she sees that as much. Maybe like they'll use like alcohol or like THC and Delta 9, but that's more like recreational. But in the vignettes, substance abuse is hard.
It's a big deal out there.
Yeah, because you have to like, some of the questions aren't necessarily what is the diagnosis. It's like, what's the first line treatment? And then in your head, you have to go, oh, that's cocaine. So
what's the symptom of the first line?
Yeah.
What's a complication of the first line treatment? I'm like, okay, I don't know the first. What if I don't?
I don't even know what this is.
Okay. Yeah, these questions sometimes.
It's like threefold. Like I first diagnose it, and then I have to figure out what the medication is, and then I got to know the side effect of that medication. It's like threefold.
Yeah. So a lot of med management that we have to observe and sometimes do on our case presentations too, which I think we both enjoy them.
Yeah.
Just learning about different patients and presenting the case.
Yeah, because yours this week, we get cases every week. And basically these are patients that she's managed and stabilized. And then we have to come up with the treatment and she'll tell us if we were right or wrong. Yeah. Which I like because it's kind of like a puzzle piece.
Yeah, but I do like them.
The patients can have a lot of trauma and a lot of things in their past. That's really tough. Very interesting. What was yours this week? Do you remember?
No.
I don't remember kind of.
It's about 18-year-old. I think primary concern is depression.
I think it was.
But sometimes it sounds simple, but it's not simple.
No.
Like they could have mood swing issues and you can't use an SSRI for.
And then they have insomnia.
Swings. And they have insomnia. Then you have to know about how to do CBTI, which is obviously the preceptor does it. Because I think that's a certification, I believe.
Yeah. I think mine this week, she had schizophrenia and she's been hospitalized twice.
Okay. Oh, yeah, I remember.
And she has insomnia.
Yeah.
So.
It's the ones that like, even like yesterday, it's like clinical, your stuff is sometimes so different because the people will have ADHD, bipolar, OCD, anxiety, depression, insomnia. Yeah. Then you have to manage everything.
But it's so weird because I'm learning that like one med will help cover two of those. Yeah. And so if you manage, like for her, she's always focused on stabilizing mood before anything else. And so, but like by stabilizing the mood, you're also helping like their OCD, their bipolar, and their anxiety, and whatever else, sleep. So it's like sometimes you just need one or two meds and that'll treat X, Y, and Z. Instead of like, I think in my head, I was like, for every single one, I have to like add a med. That's just not how it is.
Yeah. Sometimes you have to knock things off to add things on. That's what I've learned too.
That's a good way to put it.
Yeah. Because if someone is coming from like primary care to psych, you have to, I think she said it one week. You were there too, but she said something like, you have to assess their medications and then she mentally like has a checklist of this is a good med for them, bad med for them. Because if a person with ADHD comes in and you put them on an SSRI or first before a stimulant, or like those nuances that people who are in psych understand, like they know how to like do management in their own head. For example, for us, we have to like read the case, think about it. And for me, I'm overthinking it.
Yeah, I am too.
Yeah. So
she's very good at like looking at the individual person in front of her and treating that person and what they're going through. I think that's a big thing with psych is you can put someone on meds and they're stable and they're doing well, but life circumstances will throw them out of their loop, and then you have to alter their medications, alter what your regimen because of their life circumstances. And
that's also a big thing.
Yeah, she's done a really good job of that.
Yeah. You can have the best cocktail of meds.
Yeah.
But it's not going to help if you're in PA school.
Exactly. Or like hearing some of the things these patients go through, I'm like, I don't know how you're doing what you're doing, but I can see why your numbers are like your GAD and your PHQ-9 are so high.
Yeah. Perfect transition.
Yeah.
Okay, screeners. Now we can talk about screeners too. Like I guess we're just talking about our rotation.
Yeah.
So GAD, PHQ-9.
Yeah. So GADS, most people I feel like listening know what that's for anxiety.
Yeah, mine is like 25.
That's 25 out of 25.
25 out of 25 or whatever the high score is. But GAD, PHQ-9, rapid mood screener is the one that's like new. And did you know that before starting psych?
I don't know if I did. I feel like I should have, but I don't know if we learned. Like, I knew bipolar symptoms.
Yeah.
And I think that was kind of how we learned how to diagnose it. But the rapid mood screener, I don't know if I learned that.
I don't think I don't. I feel like I don't remember it, but I don't even know if we were taught, honestly.
I don't remember learning it. But I mean, she just started using it not too long ago too. So I think it's pretty new for her, because some of the patients that we got for our case studies from like a year ago, she wasn't doing rapid mood screeners on them, right?
Yeah. I don't know if it was like last year.
Yeah.
Or starting a particular month
Yeah.
when she started using rapid mood screener, but I guess rapid mood screener is just assessing their mood swings or mood instability.
Yeah.
And then you never give them stimulants or SSRIs if they're like manic.
Yeah.
Basically, it assesses how manic they are.
Because then you know that you should start them on a mood stabilizer first.
Yeah.
And then you can treat other things treat ADHD. Like the patient we had yesterday is she's been in a manic state for a few weeks.
Yeah.
And so she put her on a mood stabilizer first and took her off of her stimulant.
Yeah.
And then now that her mood is more stabilized, like last week her numbers were so high and she was still in mania. And then we saw her yesterday virtually and her numbers were down and her mood was more stabilized. So then they did like a low dose back of her stimulant to see if that would keep her mood still stable. So that's been kind of interesting.
Yeah.
It's helpful for sure.
Definitely helpful. I'm probably if I go into primary care, I'm gonna use rapid mood screener. Not that I don't know if I'm. Well, yeah, I don't know if I'm gonna get a manic.
You
Could possible.
Well, a lot of her job is like taking in people from PCP.
Yeah.
You know, and fixing their meds, because she's just so specialized in psych. She just knows exactly what she's doing.
Yeah.
PCPs, I think, have such a good understanding of it, but when you do it day in and day out, like she does, you just know the field so much better.
I'm just afraid of like, I can't say this with my chest, but like, I really enjoy primary care and like other like cardiology, ortho. I never saw myself going into psych, but considering how this rotation went for me and considering like how much I learned from this rotation and the skills I got.
Yeah.
Like, it's so hard not to think about just giving a thought about going into or just having a part-time job in psych.
Yeah.
But back to the screeners, like rapid mood screener is the one that's used. And then we both did DIVA-5 on patients for ADHD. And it's like an hour and a half test. Sometimes it takes quicker, depends on how fast you go.
Just asking literally questions because you're trying to figure out if they have like the inattentive type or like impulsive hyperactive type or combined type. Just a lot of questions to ask them.
A lot, yeah. It actually is the DSM-5, like, but it's detailed.
Yeah.
And then next is PMQ, Patient Mania Questionnaire 9.
Yeah, I don't know if I've done that one yet.
No, she has done it before, but she uses more RMS, but that's also for mania. And then Yale Brown Obsessive Compulsive Scale for OCD. That's also big.
Especially with patients when they like come in and they're struggling with it more. We've seen like a few, but not that many. Like a lot of patients have had OCD, but I think we've only really seen one or two that were actively still struggling with it or like had a breakthrough, I guess, symptoms. That's a good way to put it. I don't know.
Yeah. Some other things is sleep and CBTI. I think we already talked a little bit about it, but I think sleep and CBTI is also important in psych.
Oh yeah, especially like stimulants are going to keep you awake. So managing that. Anxiety, probably going to have issues falling asleep at night, waking up throughout the night.
Yeah.
Depression, you might be sleeping too much.
Yeah.
So insomnia and sleeping too much are huge.
Yeah, and then the CBTI is just like she talking, like giving them education on sleep hygiene. Basically doing cognitive behavioral therapy.
Yeah. See, I haven't seen her do it yet.
No?
No, because all my notes, I always have to take that part out.
She might, yeah.
She hasn't done it with me yet, but maybe next week she will. Like all of her patients, like she just will give like hydroxyzine. That's been a big one for sleep. Or trazodone sometimes.
Yeah. There are meds too for that.
Yeah.
And then with substance use, we talk a lot about substance use too, because it's obviously like a large portion of impacting your emotions, and caffeine is the big one. I mean, I eat drinking caffeine. I mean,
we basically have lattes.
So one thing I did not take from this rotation is to stop using caffeine.
Yeah, but we're less stress since didactic, so we can.
Yeah, we can. I guess we manage.
Yeah, if we can manage it well,
yeah, it
then
balances out. Yeah,
that's what she tells her patients. Of like, if you're managing your anxiety well, then like you can, have a cup of coffee. But if you're really anxious, you probably shouldn't drink that energy drink.
She would say that not to me. You, yeah.
Maybe she said that to some patients.
Yeah, she has. Okay. Managing meds and knowing important side effects is also big. I think we talked about this, but just before coming to this rotation, you made a list of brand names and generic names of medication that has helped us out too.
Yeah.
And just before starting this rotation, I think it would be beneficial to just glance over all of this second-gen antipsychotics, generic and brand names.
Yeah, I agree.
SSRIs.
Side effects.
Most common side effects. Don't have to know everything.
Yeah. Refractory, like what you do if they're refractory. I think that's a big thing, especially like...
If someone fails 2 SSRIs, what are you going to do? Like all that stuff?
Yeah. Or like clozapine, buspirone, bupropion, or Wellbutrin.
Yeah.
That was a big one for me. I kept getting buspirone, bupropion, and Wellbutrin. Which is the brand name for bupropion. Confused.
You got
Buspar for buspirone.
Buspar for buspirone.
So I did not know any of the brand names. So the first day, I would have to go, is that olanzapine? And then I'd have to just start looking them up, and then making the list was helpful because now I can pick up on some of them. Yeah. I still have to go back to my list a lot.
There's also some new kids on the block like Lybalvi.
Yeah, I don't even remember what that one is.
And there's one more, which we used it once for a person with depression, but it's bupropion plus dextromethorphan. Oh. It's like a syrup. Not sure what the name is.
Is Lybalvi the one where... Is that olanzapine plus...
Olanzapine plus suma something.
It's to help with weight gain, right?
Yeah.
Yeah.
So all these different medications. Maybe I will have a doc in the description.
Yeah.
The YouTube description and the Spotify description to refer to. If you're wondering what these crazy names are.
You can use the list I sent you.
Yeah, you can use that list. And I can put all the screeners in there too.
Yeah.
I don't think I can put the Diva 5 because it's
so
protected.
Long.
I think it's...
Is it?
Yeah.
It's also like a 36-page PDF. It's long.
Yeah, I'll ask my preceptor.
Yeah.
I can't do anything without permission these days. And then basically psych is just less hands-on than primary care.
Yeah.
That's what I feel. It's coming straight from primary care. Definitely less hands-on. Yeah.
It's a lot of... even just like for her too, like a lot of listening more than like hands-on doing. Like you said, like you're not really listening to heart sounds. I mean, we take a blood pressure.
Yeah.
Because some of the meds can increase the blood pressure, I guess, in our eyes. But for the most part, it's really just listening. Especially because, I mean, with a lot of these patients, like like you said, they can be on the perfect medication cocktail.
Yeah.
But then life circumstances throw them out of whack, and you gotta like just manage them and where they're at. So a lot of it's just listening of like what's going on in your life, how's work, how's school, how's your relationships, and it's just her listening and being a friend to them in some ways.
Yeah. Which
is different than what you'd expect for clinicals, I think.
Yeah, definitely.
Psych's just special in that.
I'm also understanding the visit lens for a specialty like psych, neurosurgery. I have cardiology as my elective in future. And I anticipate like those visits are going to be 30 minutes long. So you have much more time to talk about stuff. Because I guess in specialties, you're trying to you're trying to get to the root cause.
Yeah.
So I think I admire those 30-minute visits.
Yeah.
Than we having like 4 patients every hour. I think that would be crazy.
Kind of exhausting.
Yeah.
Because then I think it goes back to like seeing your patients as like less than yourself. Like you get in that mindset of like 4 patients an hour, check.
Check. You're just checking boxes.
You're just going from room to room
Yeah.
instead of like, even if you have 30 minutes with the patient, you still might end a little early. You have a few minutes to like catch your breath and get yourself together and prepare yourself for the next patient so that you can give them your all instead of like room. It's like you have more time to just let them talk.
Yeah.
And be a person, and you're not just like rushing through a questionnaire.
Yeah, it's a good way to put it too. But lastly, how are you managing life in being in psych rotation? I know we talked a little bit about like I think you have much more social life than what I have. So how have you managing life outside of psych rotation?
Like friendships and hanging out with people and
Yeah, because you went back home to last week or something.
back to Charleston. Yeah.
Yeah. So how do you like this new change? We already talked about a little bit of this, but like
Yeah. I feel like I can be more intentional with my time.
Yeah.
Like before, I think I would go to events sometimes because I was like, I genuinely can't study anymore. If I study, it's not going to be productive. So I might as well go to this event. And I would go, but then in the back of my head, I was still thinking like, I still don't know what this is. I still need to study this. I still didn't get to this PowerPoint. Like in my head, I'm still reeling and stressing. And then that guilt sets in of like, I should be at home studying.
Yeah.
Now I feel like I have time to where I can study and get it done. And then I'm not even thinking about it when I go and hang out with people. So I think I've just had to be intentional with my time of like, I'm going to study until I feel like I'm not being productive. Whereas before, I think I would kind of force myself to study more. And two, like I want to be there for my friends and be intentional. So part of like friendships for me is like accountability. So like meeting up with people and going on walks and checking in, like, how are you doing? How's your faith going? How's life going? How's your heart? So I just have to be intentional with my time and read myself well. Of like, do I need alone time? If so, okay, I'll spend some time by myself, or like going and hanging out with friends. So I've been thankful that I have good friends to go back to in Charleston, because I didn't know anybody when I first moved there. So, and then intentional with like calling my parents every night and making sure I take time to do that. FaceTiming my nephew. Another reason why I'm in PA schools, I look at pictures of him, and my grandma and my parents and stuff. So, yeah, I think getting out of didactic has given me more margin to where I can actually enjoy those things now instead of like force myself to go do them to get out of studying.
Yeah,
if
definitely.
that makes sense.
Yeah. Okay. To end off this podcast, I always have some rapid fire questions.
Oh gosh.
Which I have them in my brain.
Are these like the 60-second diagnoses, or are these
No,
like?
no.
Oh, these are okay.
Just rapid.
Okay.
I think I usually just have them in my head quickly. No stress.
Just answer first thing comes to mind.
Yeah.
Okay.
Did you try auspicious?
I have not tried auspicious.
Oh, you have not tried auspicious.
But the family I'm staying with, Mr. Chan, her dad, said that I'll be here next weekend. He was like, next weekend we'll go before you leave.
Okay.
So I'm gonna go next weekend with them.
Okay. Sounds good. So, okay. Best coffee shop in Savannah.
Ooh, I've only tried 2.
Okay, what's the best one?
Savannah Coffee Roasters and Origin.
Who makes good coffee?
They both were good.
No,
I think I liked Origin's coffee better, but I liked Savannah Coffee Roasters' atmosphere better.
Okay.
Because Origin was really busy.
It's loud in there.
It was loud. The line was really long. Versus Savannah Coffee Roasters was really
Not
big.
that they mind, but we as students mind.
Yeah.
They don't mind the customers.
No, they don't mind. I mean, but I honestly think Savannah Coffee Roasters coffee was still just as good as Origin. I just think.
Okay.
I think what I ordered was different though too.
Okay.
I got sugar-free vanilla at Savannah Coffee Roasters, but I got regular vanilla at Origin.
They don't have sugar-free at Origin.
So I think it was better because it was not sugar-free.
Okay. It's fair.
They were both good though, but I liked the atmosphere of studying better than Savannah Coffee Roasters.
Okay.
Yeah.
Definitely. Psych or peds?
Peds.
Still peds?
Still peds.
I guess, yeah. I mean, it's their first rotation.
Yeah,
It's
and
too
I have
early.
peds next, but I don't know. Kids are just so cute and so
Yeah.
sweet. But also too, I think when you're treating peds, like you're treating the family too. Like when you treat a kid, you're treating their mom, their
You're looking
dad.
at the family.
Yeah, you're treating their grandparents. Anyone who cares for that little baby, you're
Yeah.
caring for them as an extension. So I don't know. I just think it's like a blessing to take care of kids because people are trusting you with their little babies.
Yeah.
You know, with their everything is in your hands.
Feel that. We had some peds cases in primary care or like urgent care, and I wasn't comfortable at first, but then as I got the hang of it, I'm like, yeah, this is very important to do. Like it's just gratifying.
Yeah.
I could see that.
I mean, it's the same with PCP. Like if you treat a 6-year-old, you're treating their wife, their kids, their grandkids. Like you're treating their whole family as an extension.
Yeah.
Anyone who cares for that person, you're treating them too.
Good perspective there.
Yeah.
Yeah. Lastly,
Okay.
you had the perfect job, both in this. I'm still saying it. I'm still thinking of how to say it.
Okay.
You have the perfect job, perfect schedule as a PA in peds, but you have two options:
Okay.
Charleston or Savannah. Where would you live? Only two options in the world.
I would say, that's hard.
You have your friends. Everything is constant.
I know.
You have only two options: Charleston or Savannah. Where would you go?
I'm going to say Savannah.
Why? Why?
I love Charleston. I love all my people in Charleston. It's a little bit closer to my family being here.
Okay.
It's not maybe like an hour and a half. So it's really not that much closer.
Okay.
I love Charleston, but I'm not big on city life. And I think Charleston's a little too busy for me sometimes. I like...
Is it more party? Like, what,
No.
like just city?
Yeah,
life?
just more city. Like I would never want... Like I'm from Atlanta. I would never want to live in Atlanta just because of the city life.
Yeah.
I think I like it a little bit slower. But the good thing about Charleston when you work there is if you don't know something, someone comes in, especially in peds, they come in with a heart issue, you just refer them out because there's someone who specializes in that everywhere in Charleston. Like with anything, there's specialties everywhere. But Savannah also has a great hospital system. So I don't know. I think when I think about like life-wise, I would think I would enjoy Savannah more. When I think about job-wise, I think Charleston has more opportunities.
Okay.
So I don't know.
I could see that.
That's twofold.
Yeah.
But I love Charleston. I love my friends there. I love my life there. But it is really far from my family. That's been the biggest downside. It's like 6 hours.
Okay. Awesome.
Yeah.
Well, that's it. That was it. Thanks for watching, everyone. I hope you enjoyed this conversation.